Hello and welcome to this video entitled Management of Dry Retina Tear Without Using Heavy Liquid. My name is Emmanuel Mavrikakis. The authors have no financial disclosures. A 40-year-old male presented with reduced vision in his left eye for the last 2 days. His past medical history was negative, while his ophthalmic history includes high myopia of -8 sphere. On examination, visual acuity is 20/30 right eye and hand movements left eye. Anterior segments were normal on both eyes. He was phakic. Fundus examination of the right eye showed attached retina with myopic fundus, while fundus examination of the left eye showed a giant retinal tear from 2 to 5 o'clock with folded edges and a macula off retinal detachment confirmed on B-scan ultrasound. The surgery starts with removing the vitreous hemorrhage using a 23-gauge system. The redundant anterior retina is removed to reduce the risk of postoperative PVR. Then the folded retina is unfolded bimanually very gently. And the edge of the giant retinal break is marked with endodiaphragmy, so it is visible under air in the later stage. Which is then followed by a meticulous removal of any remaining vitreous anteriorly with scleral depression in order to minimize any risk of postoperative PVR. And again, any redundant anterior retina is further trimmed. Then, with the use of a silicone tip backflash, air fluid exchange is performed. By keeping the backflash very patiently posteriorly, and as time goes by, the subretinal fluid is gradually removed, giving the chance to the retina to flatten. And then, by very patiently removing any remnants of the subretinal fluid, the retina is finally completely attached, giving the chance of lasering the posterior edge of the gyroretinal brake, followed by a laser of the anterior part. Which is then followed by cryopexy at the horns of the gyroretinal brake, starting with the inferior horn and followed by cryopexy of the superior horn of the gyroretinal, and then the case is concluded by air 16% C3F8 exchange. The patient was instructed to remain strictly in his left side for 2 hours in order to drain any residual subretinal fluid away from his macula and to minimize any retinal macular folds. And after the 2 hours, emphasis was given to strictly face down for 5 days. 6 months follow-up, his visual acuity in that eye was 20/60, and the retina was flat without any macular fold. In conclusion, modern surgical techniques and equipment allow the treatment and rehabilitation of complex retinal detachment with good visual prognosis, while minimizing the overall surgical morbidity and avoiding complications related to heavy liquid use, including subretinal heavy liquid or any remaining heavy liquid in the vitreous cavity causing toxicity, or even inadequate removal of vitreous, and then increasing the chance of PVR in the post-operative period. I would like to acknowledge my colleagues, Dr. Athina Athanasiou and Dr. Aglaia Korobilla, and to thank you for your attention.